Hello, I'm Hartford Healthcare's Tina Verona. Tonight, we are tackling an important topic in our Facebook Live discussion. How do you treat someone in cardiac arrest who has a mechanical heart pump? When do you do chest compressions? Well, historically, it was somewhat controversial to do chest compressions because it could often lead to a fatality. But now, with a new report out, there is shedding some new light on that. And joining me is Dr. Jason Gluck from Hartford Hospital. Thank you so much for joining me.
Happy to be here.
So let's talk about this report. And this is something that's near and dear to your heart because you're a former firefighter paramedic in New York City. So you've sort of come full circle with this. You've just co-authored a very in-depth report for the American Heart Association that, again, sort of gives a different spin on this, that chest compressions are possibly good to perform on somebody with a mechanical heart pump. Let's just take it back to the beginning. Who exactly would be having a mechanical heart pump? Explain what that is.
So a heart pump is used for folks that have a failing heart. They have heart failure. And medicines alone are not able to support that person. They don't have enough blood to supply the body. They get tired, they get short of breath, and they can ultimately die. And so what this pump does is it buys them time, or it ends up being a definitive therapy to either get to a transplant or to live the rest of their life on this device and exist in a quasi-normal manner.
Mm-hmm. Now, how do you qualify a person that's just using this to sort of bridge the gap until they get a transplant versus someone who needs to be on this pump for the rest of their life?
Yeah, so there's a broad category which we call advanced heart failure therapies. That includes kind of IV medications, heart pumps, and heart transplants. So one of the first questions we ask is, what is this person a candidate for? Not everybody who has a weak heart is necessarily a candidate for a heart transplant or a heart pump. So we first put the patient through a fairly rigorous battery of tests and consultations to figure out, are they a good candidate? Will they do well with this therapy? Will they thrive? Once we determine that we think they'd be a good match for the therapy, then we determine, are they a transplant candidate or not? If they're a transplant candidate and they're interested in a heart transplant, then that's a good patient that could be used as a bridge to transplants. That is to say, the heart pump supports their heart and their body until they get a needed heart transplant. In somebody who either doesn't want or is not a good candidate for a heart transplant, this therapy can actually be used as destination therapy. That is to say, they get this device, they live with this device, and then ultimately they will die with this device after time.
So let's talk about this. This is great stuff. I mean, this in-depth report that you helped co-author, because the controversy surrounding this was more thought that if an EMT arrives on a person who is in cardiac arrest, who has this mechanical heart pump, to do chest compressions, if they feel for a pulse, they're not going to have a pulse, or their blood pressure is going to be different, or their heart is not going to sound the same as a normal person. So it was believed that chest compressions could be life-threatening. Explain how that necessarily is not the case in terms of the report that you just finished.
So, so first some background. So with these pumps, they're what we call continuous flow. So if you check your pulse or my pulse, or somebody who doesn't have a heart pump's pulse, you feel this nice bounding sensation in the wrist called your pulse. These pumps provide continuous flow. It's kind of like a swimming pool pump where the blood flows round and round and round, and there's no, excuse me, there's no pulsatility there. Mm-hmm. So they don't have a pulse. And that's what we call pulseless electrical activity for many people. So these folks are very much alive. They're talking, they're walking, they're breathing. So differentiating who needs chest compressions and who doesn't is sometimes challenging. So this paper helps kind of differentiate. In the past, we thought because they had pumps inside, if you actually did the mechanics of chest compressions, you could rupture that tube or pull that tube out that's sitting inside the heart or the main artery and cause massive bleeding and death. Mm-hmm. And what we found by reviewing the literature from a scientific standpoint is that actually chest compressions are probably not harmful. Mm-hmm. And in fact, they could potentially help somebody. So when in doubt, if you don't know, err on the side of performing chest compressions instead of not performing chest compressions.
Now, is there a certain way to perform chest compressions in this case on somebody with a mechanical heart pump so that you're not going to possibly dislodge that connection, or is it standard practice, regular CPR?
So that's the beauty. It's standard practice, regular CPR. And the nice part of this paper is it talks to all levels. It talks to bystanders, it talks to emergency medical dispatchers, it talks to EMTs and paramedics, to family members, to nurses, to APRNs and PAs and doctors, and tells everybody kind of across the board based on your role and your knowledge base when you should be providing chest compressions, which is really the default, and then when not to, which is the exception.
Now, explain for our viewers that are watching this Facebook Live discussion. This report was just recently published. What happens from here? Does this become the standard guidelines now? How does this disseminate from here?
Yeah, so this is an American Heart Association publication. It's on this journal called Circulation, which is kind of one of the more prominent journals. Most likely, this will become standard practice across the country and probably around the world.
Great. Now, that's really great stuff. And we do have a question from Laura. So it's a long question, but we're going to get to all of it. This is a general transplant organ donation question. There is a movement in European countries and a few states to use, quote, presumed consent model for organ donation. This means that everyone is an organ donor and they would have to opt out or not to be. This is different than the current model of opt-in to be an organ donor. Do you have an opinion on the presumed consent model for organ donors?
This is a fantastic question. So, there's a shortage of donors in this country and in Europe and around the world. And so this VAD stuff is to really help get somebody to a transplant if they're a candidate. Now, the way that the system currently works is, as you said, you have to opt in to be a organ donor. So most folks do when they get their driver's license or renew their driver's license. There's a question that says, are you interested in being an organ donor or not? And if you are, then it marks your driver's license in a certain manner to identify that you are an organ donor. There's a movement, as was very well pointed out, which says that rather than opt in, why don't we have folks assumed to be somewhat altruistic or assumed to be willing to donate and therefore make them opt out? That is to say, unless you tell us no, you are an organ donor. Therefore, you'd have more potential donors and more potential transplants. And this is a very interesting theory. It's a fairly controversial approach. Certainly, it seems it would increase the donor pool. That is to say, make more donor organs available. I think most transplant physicians are supportive of this model. But there's a matter of autonomy, and so it becomes somewhat of a legal issue, which is who's in control of the donor,
right.
And the wishes. So currently in this country, we tend to kind of respect the privacy of the person in
right.
that they wouldn't be a donor unless they specifically said otherwise.
Right.
From a kind of humanity standpoint, certainly making presumed consent the standard of care would increase the availability of donor organs.
Interesting debate, Laura. Thank you for that question. Something interesting back to what we're talking about with mechanical heart pumps. Some years ago, I think it was back in 2013, in your garage, most people will work on their cars or maybe fix their lawnmowers, but you actually developed an actual mechanical heart pump device to train paramedics and first responders. Tell me how you did that. What did you use and what was the sort of force behind that? I guess it was obviously the controversy surrounding this, but what did you use and how did you develop that?
Yeah, so there was a need, which is training not only EMTs and paramedics, but nurses, doctors, mm-hmm. patients, their families on these devices. And one of the ways we've historically taught people is by kind of having them meet a patient and see how the equipment works and kind of trying to show them how to do things like change batteries, change a device, understand what a VAD hum or the heart sounds that a normal person are replaced by. So normally you hear that lub-dub, which is the
right.
heart sound.
And just for our viewers, explain what an LVAD is.
So an LVAD is a pump that goes into the heart, and it really helps the left ventricle, which is the main pumping chamber of the heart, get blood round and round. So the body has the heart has one function, which is to get blood round and round. And when the heart gets too weak to really get blood round and round, this device, exactly like it says, assists the blood to go round and round.
So how did you actually develop it? What did you use? What were the tools?
So we took a regular old CPR Annie that
yep.
most folks who've taken a CPR course are familiar with,
mm-hmm.
and we modified it to allow it to kind of accommodate one of these pumps. So there's actually a pump inside the Annie, and we actually have two. We have two different types of pumps we use here at Hartford, so one for each type of pump so that they could learn based on which pump they're getting. And then coming out of that Annie is the same drive line or power line that someone would get that comes out of their body, and the same peripherals, the same controller and batteries that connect to this device and this simulator. And so when one puts a stethoscope on the simulator, just like you would hear a VAD hum in a human, that has an LVAD, you would actually hear the VAD hum in the simulator.
Right.
And just like if you disconnected accidentally the batteries from a human, the pump would stop, so too would it in this simulator. And so it allows us to not only train people on what's right and what's normal, but what's abnormal on some of the alarms, and then even one step further, which is what's the intervention? How do I change a battery? How do I change a controller? And they can practice it safely, because if they make a mistake on the simulator, it's no big deal.
It's no big deal.
If you make a mistake on a patient by accident, it could be devastating.
Is there anything different in CPR that they need to alternate with a person with on a mechanical heart pump, or no?
Again, the beauty of this thing is, based on our scientific analysis, there's no need to change the way we do things. So the typical way we do it is how you should do it.
Is how you should do it. So what really is the takeaway message here, folks, in heart failure?
So I think the main thing that is important to know, number one, is heart failure is treatable. So if someone's diagnosed with end-stage heart failure, it's not necessarily a terminal diagnosis. So if one hasn't been seen by a heart failure specialist, there's often a role to be seen by them. And most cardiologists are very well educated on how, if, and when to refer to heart failure docs. So if you have heart failure, you've been readmitted a couple times, or you're concerned that your EF is very low or something like this, and you haven't been referred, it's always appropriate to ask your doctor, do I need to see a heart failure specialist? Much like there's a cancer specialist, there's a heart failure specialist. The other thing that one should know is that chest compressions are safe in these patients. Unless you've really been told not to do them, at this point in time, our recommendation is you should. And then when a heart failure specialist, or someone who's been trained in this VAD, a family member that's been trained in how to do this, tells you differently, then adjust your process. But first and foremost, if you don't know, treat the patient like anybody else.
Yeah, and here at Hartford Hospital, there is, some 40 patients that are currently on a mechanical heart pump assisted device?
Correct. We currently have about 40 plus patients in the community on this device.
Mm-hmm. And we've performed about 100 or so of
So Hartford Hospital has done a little over 100 in total since we started, which I believe was around 2008.
And this is an implantable device?
Correct.
That,
it's a surgically implanted device.
All right. Well, thank you very much, and good work on co-authoring that in-depth report again for the American Heart Association. We thank you for that. There are a number of CPR classes for family and friends to take that Hartford Healthcare offers. You can call that number on your screen, 1-855-HHC here, to register. So thank you once again for joining us in this live Facebook discussion tonight. I'm Hartford Healthcare's Tina Verona. We'll see you right back here next week.